conjunction with the International Women's Day this month, today's BizTech Health and Wellness show is focusing on women and children's health. Joining us on the show are two doctors from Sunway Medical Center. They are Dr. Janani Sivanathan, consultant in Obstetrics and Gynaecology, Maternal Fetal Medicine, and Dr. Kian, consultant in Paediatric, Nephrology. Dr. Janani and Dr. Yiaw will be speaking on high-risk pregnancies and kidney disease in children. Welcome to the show, doctors.
Hello. Nice to meet you, Sharon. Yeah. Hi, everyone.
Hi. Before we go into the discussion on high-risk pregnancies and kidney diseases in children, both of you have very interesting subspecialties. Maybe Dr. Janani, can you share with us a bit on your subspecialty, which is in maternal fetal medicine?
Okay, so maternal fetal medicine is a subspecialty in obstetrics and gynecology, one of the four. The other subspecialties are in gynae-oncology that deals with cancers, urogynecology that deals with the waterworks of women, and fertility, which obviously is for artificial reproductive techniques. So maternal fetal, as the name itself says, it encompasses two parts of the mother, wherein we look after women who have got pre-existing medical conditions, as well as conditions that develop during pregnancy, as well as we look into the fetus or the baby when in the mom's womb to detect any problems or abnormalities in the baby.
What about you, Dr. Yiaw? Can you explain on what is pediatric nephrology?
Yeah, so I think you can actually split that term into two words, right? I'm sure the public will be very familiar with nephrologists, right? In view that we have a 40,000 adult on dialysis row now. So I think, so of course, when you come to peds nephrologists, okay, it literally translates that, any children disease, children with a kidney disease, when they are younger than 18 years old. Then my role is mainly to diagnose, to treat, and to manage, all these kidney disorder among the children, be it the kidney tract anomaly, or they have some infection or high blood pressure, or any genetic related kidney disease, as well as a kidney stone. So I mean, anyone that below 18 years old with kidney problems, you will fall under my responsibility. Yeah. So including dialysis and transplant. Yeah.
Generally, for women, having a baby is a natural process. After a full-term pregnancy, women go into labor either on or near their due date and give birth to a healthy baby. Dr. Janani, what is a high-risk pregnancy and the complications that could occur?
Okay, so high-risk pregnancy is one of greater risk to the mother or her fetus compared to an uncomplicated pregnancy. So pregnancy is not a disease. However, it does place additional physical and emotional changes or stressors onto the woman's body. So if a woman is already predisposed to an underlying medical condition such as diabetes or high blood pressure, heart diseases, kidney diseases, autoimmune diseases, or thyroid issues, these may either remain stable or worsen in pregnancy. This in turn may affect the development of the fetus, such as causing birth defects, growth restriction, preterm birth, and higher chances of stillbirth compared to the general population. Other than these underlying medical conditions, some women may have recurrent miscarriages or cervical weakness or insufficiency with pregnancy loss, multiple or triplet pregnancies, carriers of genetic disorders, which all put them in this high-risk group. Okay. As to what are the complications that could occur, they may develop gestational, that means diabetes in pregnancy, preeclampsia, which is the high blood pressure and losing of protein in the urine, and other such complications.
How do actually, you mentioned the complications. So what can a mother do to actually, to, you're going to say to actually, to minimize the risk, or is there a way to, or is because they are already having that kind of problems, that kind of complications that also it will lead to the pregnancy of the mother?
So yeah, so they already may know that they have all these medical problems. So what is pertinent is actually the woman should go for a preconception clinic before she is pregnant and see the doctors, the specialists to see if her medical condition is actually stable, in remission, and if it is safe for her to conceive at this point of time. Even the cardiologist, if there's a heart disease, so they can advise on the safety of her pregnancy at that point of time. And then once she's already pregnant, obviously it will be a multidisciplinary team management, wherein it involves the maternal fetal medicine specialist, as well as the other specialists involved from the other teams, such as the rheumatologist or the nephrologist, as Kian is, for pediatric base, but adult nephrologist, to co-manage the mom during the antenatal care. And then if, for instance, there is a problem in the baby, then we get the neonatologist involved so that the parents can be counseled on what to anticipate in these kind of problems, and then a care of plan for the antenatal as well as the intrapartum or during labor is discussed together and set out so that everything has been prepared. Yeah.
Dr. Janani, when there are instances where there are multiple births, right? Will the mother be, carrying twins or triplets? Does it actually increase the risk of premature labor? Or
yes,
definitely.
definitely.
High blood pressure?
Yes, definitely. So multiple pregnancy itself is a high-risk pregnancy. Not only does it predispose to diabetes, high blood pressure, or preterm birth, there are higher chances of miscarriage, fetal defects, fetal growth restriction, stillbirth rate increases, and there's risk of venous thromboembolism, that is blood clots occurring in either the legs or that goes to the lungs, pulmonary embolism, and upon delivery, postpartum hemorrhage, as in there's more bleeding, more frequent delivery by cesarean section. So these are the problems that
what's the percentage like, Dr. Janani? Women carrying multiple births and having this kind of complications.
So it depends on, multiple births itself. There are various types. So even in twin pregnancies, it depends on whether the babies are sharing the placenta. These are called monochorionic twins, or whether each twin has its own placenta. So those are dichorionic. So the risk is lesser when it's a dichorionic. Monochorionic, the risk are further enhanced. So there is risk of something called twin-to-twin transfusion syndrome, which occurs in like about 30% of pregnancies. So across the board, risk of preterm labor is about 60%. So risk of stillbirth is about 50%. So depending on the type of twins or triplets but nevertheless, it is high risk and higher chances of complications.
Maybe Dr. Yiaw, you can share with us on this, yeah? When the pregnancy is high risk, what are some of the actually health complications that could occur in the different stages of a child's life, for example, as a fetus, baby, toddler, even to an older child?
Right. I think this is quite a big topic, you see. So I think we probably need to dissect to a few elements. Really much depends on what is the maternal complication to begin with, right? Let's say, for instance, if the baby is born prematurely, right? So we know that those baby who are actually less than 30 weeks or whatever, their lungs may not immature enough to breathe on their own. So they will need ventilator support, and they are all very tiny, and to look after for. And then in that case, okay, all these premature baby, okay, when they're born too small or too young, okay, they're subject to more complication compared to term baby, okay, be it in the lung development, be it in the brain development, and also the subsequent care, yeah. So they are prone for more infection, during the early stage of life, and of course, then you're talking about if a mother have a diabetes or and so on, the baby actually are more prone for congenital anomaly. Okay, they can have what you call that the heart defect, okay, and also kidney tract defect, and so on, right? And for those mother who at one age kind of things, so we do know that, okay, they are actually at the increasing risk of getting a Down syndrome baby. So for instance, any mother who are actually pregnant at after 40 years old, so if there's a 1 in 100 chance of getting a Down syndrome baby. So it's really very much depends on what is the maternal risk factor to begin with. Yeah. So yeah.
So what about for children? When it comes to children, what are the factors that actually could cause kidney disease? I mean, and it's such a young age, right?
Yeah. I think for these things, I think we need to stage them according to their age, because the causes and etiology are very different. Basically, those less than 4 years old, okay, most of the kidney disease are actually focused into the structural aspect of kidney. They might born with a lousy kidney. They may be born with some blockage in the urinary tract kind of things. Yeah. So then this little predispose them to get an infection in the kidney tract. Yeah. So and for those who are actually 4 years and above, okay, so the issue that we usually encounter is like big wetting. I'm sure most of the public will aware that the children after 4 years old, they're still on diaper, they're still wetting their bed and until school going. So this is one of the major issues that we see in Malaysia. Okay, and the other thing is like the other cause of a kidney problem is the inflammation of the kidney. Okay, it's not really infection related. Okay, so we generally group all these things under a term called glomerulonephritis. Yeah, it's not. It's about it's not commonly seen. Okay, but when this happen, okay, it can actually lead the child into dialysis. Yeah. So, yeah. So for those school going children, mainly what we tend to see is they have this problem called dysfunctional bowel bladder. Literally means that, okay, they're so used to voluntarily hold their bladder and constipated, end up the bladder become dysregulated, when passing urine. Yeah. So yeah.
So what's the percentage like for children going for dialysis?
Of course, children on dialysis, it's just a fragment, of what Malaysian adult of the Malaysian adult dialysis cohort. At this point of time, I'm talking to you. Okay, there's 1,000 children on chronic dialysis room, and 600 of them actually are less than 40 years old. Yeah.
They're very young, yeah. And how often do they need to go for their treatments?
Pardon?
How often do they need to go for their treatments?
I think it's all depends on which modality you choose, okay, because we have two dialysis modality. One is the common one, the one that commonly known by public is the hemodialysis, means that dialysis through the blood, right? And the second one is called peritoneal dialysis, means we try to remove the toxin through the stomach cavity. Yeah. So different modality, the frequency and duration of dialysis will be different, right? Generally, hemodialysis is like 3 times a week, you know, and every session run about 4 hours. Yeah. So, but peritoneal dialysis is basically how to say everyday business for the child and the family. Yeah. So it really depends on what modality we're talking about. Yeah.
Can they do it at home?
Yes, for
come to the hospital.
Yeah, I think the benefit of peritoneal dialysis in the sense that children and family can have that done at their home, and so that less disruptive to their normal activity at school life. Yeah. Unlike hemodialysis, they need to come to hospital. Yeah.
Dr. Yiaw, can you share with us some of the signs and symptoms that parents actually should look out for?
Yeah. Yes. Obviously, I think how to say it's important to detect the kidney disease early, right? Because if we detect early, we can still try to reverse the damage or try to limit the damage at the most. Yeah. So unfortunately, I think every year we are seeing how to say a patient, all these children come in, okay, with symptoms that have been lasted for years, or you know, and by the time they come to us, it's really too late for us to do anything. I think the main thing, the main thing about kidney disease in children is that it doesn't have a specific signs and symptoms. You know, all the signs and symptoms are very vague. Okay, for instance, a child with kidney disease that has been a long-standing one. Okay, the child do not grow well. It tends to look small and skinny. You know, and also they look pale, not very energetic. You see, all these things, all these symptoms are not very clear-cut, pointing towards the kidney disease. It can be anything of your body that goes wrong, right? Yeah. So I would say that okay. I think if my advice to parents would be like, okay, if your child has fever, especially the younger they are, okay, they have fever, don't simply brush it out and say that this is something benign and you know, I would just give you some paracetamol and things settle, right? Because most of the times, how to say, most of the times when we encounter kidney disease, okay, it can be a urinary tract infection, can be long-standing, and if leave without any treatment, the kidney function will just go down the hill, right? And then second thing, in the sense that if your child, okay, looks smaller than your other children, you know, and don't just ignore it, okay, and condemn on their diet pattern. Because we know that a prickly eater, you know, they tend to grow small wherever. This is usually why we find the excuse to how to say, to exempt them from further examination. But I would say that if your child looks small and, you know, than your other children and they look pale, you know, go and seek a medical advice, proper medical advice. And of course, okay, the other sign and symptoms would be like when the urine become red color or become like very frothy, like the root beer that you used to take. All right, this is also not a normal sign, you know, that one should have. Yeah, so I think generally these are the things that one should look for. Yeah.
So for an adult and a child, so facing kidney diseases. So is there a lot of difference?
Yeah. Well, I think it's not easy. How to say? I think it really depends on. Okay, first of all, the cause of causing kidney disease in adult and children are entirely different. All right. As we all know that okay, adult kidney disease are mainly due to our lifestyle. We overeat things, you know, and obese kind of thing. So we know that 65% of the end-stage renal disease in adult are due to diabetes mellitus, and 10% are due to hypertension. Obviously, you don't see this kind of etiology in children, right? Okay, so for children, okay, for those who develop, who end up needed dialysis support, 25 to 30% because of the congenital anomaly of the kidney tract, which will be a Dr. Janani field, right? To pick it up early, right? And and the other 25%, okay, are due to inflammation of the kidney, which they acquire later on, not due to infection, okay, but it just somehow like I'll call the autoimmune disease kind of related, right? So the causes are different. That's one thing. Second thing is like the burden of looking after a kidney disease in children and adults, okay, especially when they come into a dialysis support, then the cost needed to look after a child with end-stage renal failure is a triple the amount that you need for adult. Yeah, so it's very costly treatment. That's one thing. And technically, it's very challenging. Yeah, but other than that, okay, Malaysia do provide, okay, A to Z treatment for all children with kidney disease, down from, how to say, controlling the disease from becoming end stage until renal replacement therapy in all form of dialysis and kidney transplant. Yeah.
So what other kinds of treatments for children? Is it actually curable?
I think it's very much depends on the cost, right? Yeah, it depends on the cost, okay? I would say that those born with, even those born with congenital anomaly of the kidney tract, okay, not all will be so great. Some after surgical repair and over time, they will grow out of it. Okay, but for those how to say who born with really lousy kidney and literally how to say barely function kidney, yeah, they will need dialysis support in the very beginning, you know, until they get a new kidney transplant. So it's literally depends on the cost and etiology. Yeah. So of course our role here in the sense that we try to sustain the kidney function, right? Until the child, how to say, grow to an older age, you know, waiting for the disease to burn out, okay? And at the same time, okay, try to limit the further damage to the kidney. So yeah, there are a lot of varieties of treatment available for child with kidney disease. Yeah. So.
Yeah, Dr. Yiaw, sorry. From your experience, maybe can you share with us a case that you have actually managed?
Yeah, I think so. Yeah, I've been trying to figure out which story should I tell. You see, because I've been managing children with kidney disease from birth until 18 years old. You know, from those how to say, from those who successfully get a kidney transplant, till those who do not manage to get to that stage, right? If I want to say of any story, I probably would just put off one of these teen. Is indigenous tribe from Kuala Baru, right? Okay. Because you have to understand, our field is very niche. Yes. So literally, how to say, the center that cater for dialysis for children, okay, only center, how to say, in one or two center in the Klang Valley. So this patient actually have underlying disease due to inflammation and eventually went to end stage, right? His housing condition is something that probably you will not appreciate very well. They're literally living in the hut. You know, the hut, just a bamboo hut kind of things. So they travel, but at one stage, we're no longer able to keep the kidney function, and the child needed dialysis support. So the mother literally traveled like 20 kilometers down from Kuala Baru 3 times a week to come to the hospital for dialysis service. And the good thing in the sense that I think I think 4 to 5 years down the line, eventually he received a kidney transplant. Okay, from a cadaveric donor. So yeah, so they kind of changed their life. But I mean, it's like it kind of registered in my mind because you see, these are all illiterate. They are not really well educated in the first place. Yes. But the mother determination to save the child, they really motivate them to go on and go on. It's not easy to be in their position and continue that, you know, for years. You know, you imagine like taking the bus, spending hours on journey just for the life-saving dialysis. Yes. Yeah. So I think that kind of touched me, you know, because yeah. So in the other word, okay, in Malaysia, okay, we can still perform dialysis and transplant for children. Yeah, irrespective what your race is and what your hierarchy is. Yeah. So.
Okay. Coming back to you, Dr. Janani. Modern women nowadays, right? They tend to have children later in life. So when it comes to geriatric pregnancy for those who are actually giving birth above the age of 35 or even touching their 40s, would the risk be actually higher, even if it's a first birth?
Yeah, so actually we wouldn't use the term geriatric because women getting pregnant above the age 35 nowadays is sort of like the new norm. So
Okay.
We are
more
all
women,
geriatric by the definitions of it.
so what we would say very advanced maternal age is actually more than 45 years old. So 35 and all is considered quite okay, but though by definitions it's advanced maternal age. So most of my patients are actually 40 years old,
Oh,
even in their
okay.
first pregnancies. Mainly because women are seeking having education and postponing their pregnancies, or they may be working in a male dominated field which do not support motherhood as much, or there might be lack of childcare, workplace policies, and so they might think that they can't be a wage earner as well as a mother at the same time. And there's also cultural and value shifts where women are not really ready to have a child. In addition to that, with the advancement of fertility care or artificial reproductive techniques, women who previously probably could not conceive on their own are given the chance to conceive, and hence why they are getting pregnant at an older age. So definitely, advanced maternal age carries a higher risk, as these women are already at older age group, and because of that they would be more predisposed to medical problems such as diabetes, high blood pressure, heart problems, and other than that, there is risk of multiple pregnancies because it's higher within the older age groups, as well as those who have had a fertility treatment. Abnormal placentation, that means the placenta is low lying, and in these women, there's higher risk for intensive care unit admission, delivery by cesarean section, blood transfusion due to bleeding during delivery, prolonged hospital stay, and venous thromboembolism. So the risk actually increases as we age. Yeah.
So isn't multiple birth like twins or triplets, genetic?
Yes, that can be in certain cases. However, as the women age as well, the chances for multiple pregnancy increases, especially if it's a spontaneous or they conceive on their own.
Okay.
But in the current era, most of the multiple pregnancies are due to IVF or things like that. Yeah.
I see. Dr. Janani, how do you manage the emotional or the mental wellness of the mother when it comes to a high-risk pregnancy?
I think the women is already prepared from day one, when she already is either preconception, that we do explain what to anticipate as she gets pregnant and as she goes through the first, second, and third trimester until labor and delivery and postpartum. So once she's pregnant in the first trimester itself, we will also reiterate all the risk, and so the woman is mentally prepared. So these women usually, I mean, they are quite strong. I mean, as we know, women are very strong-willed, and
Yes.
yeah, so they do handle it pretty well. It's just if things happen unexpectedly, so everything has been going fine, and then suddenly, boom, something happens, or that we detect some problem in the baby, and that becomes a bit of an roller coaster ride for the couple, as in, because this is, they were expecting an uncomplicated pregnancy, and then suddenly something comes in. So we do sit them down and counsel. That's why it's important to get the other specialities in, so that they are fully informed regarding the problem that they are facing and what are the measures that can be taken to outcome for a better outcome for either the mother or the baby.
Dr. Janani, can you share with us a complicated high-risk pregnancy case that you have managed before?
Okay. I guess I will just mention about the case that I just had this morning.
Okay.
That was so basically this is a staff, medical staff. So being a medical staff itself is sort of high risk.
Why is that so?
Yeah, because we tend to overlook our own symptoms. We tend
I
to
see.
our severity and yeah. So
Yeah, so it's a thing amongst medical staff that when the staff is a patient, they are already like at high risk because
because I would think that, I mean, medical staff, I mean, from the same hospital, you'll be more aware, more vigilant, because, like you have I mean, if you're facing any slight complication or problems, you just run to the doctors.
Don't worry, we try to rationalize it and try to think that it's just some minor things, so yeah.
Yeah, probably because you think you're in the profession and so you downplay it and think, nah, it's okay, kind of thing. But this patient of mine was actually from another state. She is advanced age, around 39, and this was her first pregnancy, which conceived by IVF after 6 years of marriage, and it was twins. She did not have any prior medical problems. However, she was in the first trimester when I saw her, she had increased risk for developing preeclampsia based on the screening that we do. And so I had started her on blood thinning agents such as aspirin to prevent preeclampsia from setting in. Pregnancy went on well. However, she developed preeclampsia at the later stage in pregnancy at the 3rd trimester, almost at about 35 weeks onwards. And she was also hospitalized for pneumonia. In this COVID era, coming with fever as well as respiratory symptoms is always, a worry that it may have been COVID, but it was just a bacterial pneumonia. So even in that case, she actually went to another hospital first, and they were worried to take her in because of the high risk that she was. Her blood pressure was going up. It was a twin pregnancy, IVF and all this, that they were a bit reluctant to take her in. And so she came back to my hospital, and she was admitted here and treated and all that. And because she developed preeclampsia, so we had to start her on anti-hypertensives to stabilize that, as well as blood thinning agents, injections, because she's at higher risk for developing blood clots in the leg and things. Then she was discharged well, and she had a cesarean section as a mode of delivery. The babies were born well. However, she did have a bit of bleeding during the operation, a bit more. Definitely, we would anticipate that because the womb is stretched out more because of 2 babies. Yeah, so that was an example of one of the cases. Yeah.
So with the complications and with the treatments, right? So would it actually harm the fetus, the baby?
So all the medications that we use in pregnancy is obviously safe for the mother and the baby. So we need to be aware of medications that would be safe, and we avoid the medications that that may harm the baby. So definitely, even so, women who already are diabetic or hypertensive on certain medications, it is all changed to the ones that are safer in pregnancy once or just before they start conceiving or once they've started, once they are pregnant.
So Dr. Janani, what advice would you give women who might want to know how they can actually increase their chances of having a healthy baby?
Okay, so generally, if they're on a journey or trying to embark on a pregnancy, it would be advisable to go and seek specialist care at a preconception clinic just to ensure that their general well-being is okay, or if they actually have prior medical problems, that is all stable, and given the green light to actually embark on a pregnancy. And pre-pregnancy folic acid of 400 micrograms or 5 milligrams, that's what the standard one that we have, 2 to 3 months before trying to conceive. Keeping a healthy lifestyle, as in eating well, not eating healthy food, exercising, avoiding pollutants or external radiation, and then once they're pregnant, to have a proper antenatal care, and their first trimester. In the first trimester, there's certain screening tests that can be done to see if there's any risk for the baby, as well as for the mother to develop preeclampsia, and then followed by a normally scan, which is a detailed scan, to detect if there are any problems in the baby or if the baby is structurally normal. And following that, growth scans, and we will also be doing glucose tolerance tests to see if the mother would develop diabetes or gestational diabetes, keeping an eye on her blood pressure, especially towards the third trimester, assessing for risk of venous thromboembolism or blood clots in the leg at every opportunity when she comes for antenatal care. So if all this is done, then there should be an healthy outcome for both mom and baby at the end of it. And obviously a discussion regarding the mode of delivery between the couple and the obstetrician.
Okay, finally, Dr. Janani, any tips for pregnant women or pregnant mothers who actually are listening in today?
Pregnancy is a very joyful period in one's life. It's a change that occurs that will change you entirely. So what I would say is enjoy your pregnancy, do things that would make you happy, either paint or sing, listen to music, do things like that, and start bonding with your baby as soon as you're pregnant, because that is very important. So talk to your baby, and that bonding should develop from within, and that is also shown to actually improve the baby's bond with the mom once the baby is born. So yeah.
What about you, Dr. Yiaw? Any children care tips for parents whose children who might need specialized care in terms of kidney complications?
Right. I think I echo what Dr. Janani mentioned just now. A proper pregnancy care and planning is very important. Because you look at our own Malaysian statistic in the sense that 13 out of 1,000 birth will have a thalassemia. It's a disease that affects the red blood cell, that making it not able to perform the desired job carrying oxygen to the body. So, and this group of the children, who suffer from the disease will require a very regular blood transfusion, and their lifespan is shorter than the others, children. So I think it's very good to because since it's a very highly prevalent disease among our population, it's good for both those couple who plan to who plan to have a kid kind of things, okay, to have a genetic testing before embark, to go on pregnant or whatever. And the second thing, in the sense that there's something called neurotube defect. It's basically the incomplete fusion of the backbone that making the what I call that the defect on the spinal cord. And the prevalence is actually quite high in Malaysia, in 2 in 1,000. It's definitely higher than all the developed country. And once the baby is born with that kind of a defect, okay, they're going to leave the child in permanent disability in terms of movement and also the bladder and bowel function. And this can easily be corrected just by giving the pregnant woman, on a folic supplement like what Dr. Janani said. So that's why I say it's good to have all those what you call that women who plan to pregnant whatever to plan their pregnancy early, and go to a certified doctor to have all the checkout, or scan or whatever. Yeah. So secondly, in the sense that don't simply treat yourself with unnecessary medication, because so we know that some medication actually can affect the baby growth during pregnancy, and just like some blood thinning agent kind of thing. So we have seen that happen again and again in this part of the country, in this part of the world. Yeah. So this is something that can be done by all the women in this country. Yeah. So of course in subsequent once for all those children they're under your guidance. Okay. Just be cautious of using any unconventional medicine or any home remedy, when the child falls sick or whatever. Unfortunately, I think so. We are still, we still can easily find these illegal. I wouldn't call it drug or medicine. I would just call it some home remedy in the market, readily available, but contain high heavy metal and also steroid, and this is not good for the child and even for the kidney health. And for those who have a child with a chronic kidney disease, I empathy them, okay? I feel with them because it's a lifelong journey and it's something that, you can't get away but live with it. So with that, okay, my advice to them is just try to adhere to your doctor's management, all right? And also, again, just like what we have discussed earlier on, okay, always be vigilant and watch out for any signs and symptoms that point towards kidney disease in children. For instance, like I mentioned just now, poor growth, okay, poor weight gain, or the child doesn't have a recurrent fever with unknown source. Yeah. So if your child experiences any of this, bring him or her to a proper medical checkup. Yeah. So that's probably my advice to them. Yeah.
Thank you, doctors, for taking the time to be on our show. I'm Sharon Chang, and I've been speaking to Dr. Janani Sivanathan, consultant in Obstetrics and Gynaecology, Maternal Fetal Medicine, and Dr. Yiaw, consultant in Paediatric Nephrology. This video will be on our Facebook and LinkedIn site, as well as on our website, www.biztech.asia. Please check out our website for business and technology conversations.